Hello students, we will discuss today a very important topic, antimicrobial agents, antimicrobial resistance. So the various learning objectives of today's session include, we will classify antimicrobial agents, we will also discuss the various antimicrobial resistance, intrinsic and acquired resistance. We will differentiate between the mutational and transferable antimicrobial resistance. We will also discuss the various mechanisms behind antimicrobial resistance. So, what do you mean by antimicrobial agents? Antimicrobial agents are the agents that are used either to kill or inhibit microorganisms. Okay, so the concept of antimicrobial agents was there since the ancient time. Paul Ehrlich was the scientist who is known as the father of chemotherapy. He has introduced a molecule known as salvarsan. This he had used for treatment of a sexually transmitted disease known as syphilis. Salvarsan was an arsenic compound. He has used this for the treatment of syphilis. So he is known as father of chemotherapy. Soon later, in 1940s, it was the great Alexander Fleming who has discovered the first antibiotic of the world, that is penicillin. Following which there were so many antimicrobial agents which were discovered, and that has brought a great reduction of mortality in terms of infections. Okay. So the infectious disease were treated after the discovery of penicillin, and that was a great invention to the science. Okay. So how you will classify the antimicrobial agents? Can be classified based upon various ways. The first is according to the spectrum of activity, which can be classified as antibacterial, antiviral. Antibacterial will kill the bacteria, antiviral will be targeted against the viruses, antiparasitic and antifungal. Okay. They can also be classified based upon the nature of action, whether they will kill or inhibit the microorganism. All the antimicrobial agents will not be killing. Some of the agents may just inhibit the microorganism also. If they will kill, those agents are called as cidal, that is example bactericidal, virucidal, fungicidal, and if they are inhibiting, then those agents are named with a suffix static, example bacteriostatic. Okay, bactericidal means they will kill bacteria, bacteriostatic means they will inhibit bacteria. Can also be classified according to the source from which the antimicrobial agents are derived. Most of the antimicrobial agents are derived from various microorganisms. Okay, various microorganisms, they produce antibiotic, those are called as antibiotics. So if the source is from other microorganisms, those kind of antimicrobial agents are called as antibiotic. If the source is by chemical synthesis, then those antimicrobial agents are called as chemotherapeutic agents. If the source is by chemical synthesis, then those agents are called as chemotherapeutic agents. Okay. We can also classify the antimicrobial agent based upon their uses, where you are going to use. If they are going to use inside the body, or you are going to use on the surface of the body, or you are going to use in the environment. The antimicrobial agent what you are going to use for the environmental cleaning, environmental killing of the microorganism, those are called as disinfectant. The agents which are used for body, inside human body, are known as antibiotics, and those are used on the surface of human body. Those are known as antiseptics. They are topical agents. They will be used on the surface. You can also classify the antimicrobial agents based upon their chemical structure and mechanism of action. This slide will show you what are the various mechanism of action of antimicrobial agents. They can either inhibit the cell wall, they can inhibit the protein synthesis, or they can inhibit the cell membrane. They can also inhibit the synthesis of nucleic acid, or they can also inhibit the various metabolic pathways. Cell wall inhibition, these are the antibiotic, among which the most important is beta-lactam antibiotic. Protein synthesis inhibition, either by inhibiting the 30S ribosome or by inhibiting the 50S ribosome. These are the various antimicrobial agents under each category. Polymyxin B can inhibit the cytoplasmic membrane. Nucleic acid inhibitors include fluoroquinolones and others. Similarly, metabolic pathway inhibitor include sulfonamides. So these are the overall classification of antimicrobial agents. So we will discuss one by one, and we will discuss under their mechanism of action. So to start with, we will discuss the cell wall inhibitor antimicrobial agents. Okay, so the cell wall inhibitor antimicrobial agent, the most important among which is beta-lactam antibiotic. Okay, a beta-lactam antibiotic is one of the most widely used antibiotic. Okay, one of the most widely used antibiotic in the hospital. The mechanism of action of beta-lactam antibiotic include, they act on the cell wall. Okay, they act on the cell wall protein known as penicillin binding protein. The penicillin binding protein, this is a transpeptidase enzyme in nature. This protein is transpeptidase in nature, which is required. This is a normal protein present in the cell membrane, outer cell membrane, and this protein is transpeptidase in nature. This is required for cell wall synthesis by inducing cross-linking of the peptidoglycan layers. Okay, so this transpeptidase enzyme is required for cross-linking of the peptidoglycan layer, and penicillin binding protein is a normal protein. It is essential protein for cell wall synthesis. Beta-lactam antibiotic, they bind to this protein and they inhibit this protein. As a result, what happens is cell wall synthesis get inhibited. Transpeptidase will get inhibited. As a result, peptidoglycan layer synthesis will get inhibited. As a result, the cell wall synthesis gets inhibited. So this is how the all type of beta-lactam drug, they work with this common principle. Okay, so now let us discuss how is their mechanism of resistance. Beta-lactam drug, they undergo they show resistance by various mechanisms. All beta-lactam drug, okay, the most common mechanism is by enzymatic inactivation. Enzymatic inactivation, they produce various enzymes known as beta-lactamase enzyme. The classical example of beta-lactamase enzyme is penicillinase. There are various beta-lactamase enzymes we will discuss towards the later slides of this session. So this kind of beta-lactamase enzymes, they break down the beta-lactam rings. They break down the beta-lactam rings. Okay, You know why these antibiotics are called as beta-lactam antibiotic? Because in their chemical structure, they possess a beta-lactam ring. Each antibiotic under a beta-lactam class of antibiotic, they vary from each other in their chemical structure, but they have a ring which is called as beta-lactam ring. And these enzymes, beta-lactamase enzyme, they break down a beta-lactam ring, thereby they inactivate the drug. Okay, this is their first mechanism of action. The second mechanism of action is by altering the target. Which is the target of beta-lactam antibiotic? They act on which protein on the cell wall? Yes, they act on penicillin binding protein which is present on the cell wall. So the penicillin binding protein gets altered to a penicillin binding protein 2A, or maybe some other protein also. So this altered protein has less affinity for beta-lactam drug. This altered protein has less affinity for beta-lactam drug. Normally, in a normal bacterial cell wall, the beta-lactam, they usually bind to a penicillin binding protein. As a result, the penicillin binding protein gets inhibited. As a result, the cell wall synthesis get inhibited. In this case, when the organisms show resistance to beta-lactam, what happens is one of the mechanisms is alteration of the target, where the penicillin binding protein get altered to a altered protein known as penicillin binding protein 2A, which has less affinity for beta-lactam drug. As a result, the beta-lactam drug will not go and bind, and therefore the cell wall synthesis will not be inhibited. The cell wall synthesis will not be inhibited. This is how the mechanism of resistance. So this mechanism of resistance by alteration of target usually shown by gram positive bacteria. The classical example is MRSA, that is methicillin resistant staph aureus. The methicillin resistant staph aureus is a subtype of Staphylococcus aureus which show resistant to beta-lactam antibiotic by alteration of target. Whereas the enzyme inactivation, which is the most common method of resistance shown by the beta-lactam drugs, this is exhibited by both gram positive as well as by gram negative organisms. Okay, they have a third mechanism of resistance also, which is decrease in permeability. Decrease in permeability of the cell membrane, so which result in improper penetration of antibiotic into the cell. Okay, so these are the broad mechanisms by which beta-lactam show resistance. So next we will discuss the various classes of beta-lactam antibiotics. Beta-lactam antibiotics include a broad range of antibiotics which can be grouped into various classes. The first group is penicillins, which include penicillin G, procaine penicillin, benzathine penicillin. Okay, so all these penicillins, the mechanism of action is same what we have discussed. The mechanism of resistance is also same what we have discussed. I will just tell you where they act, which organisms they act. They act on various organisms like beta hemolytic streptococcus. They also act on Corynebacterium diphtheria, meningococcus, gonococcus, enterococcus. Okay, then they also act on Treponema pallidum. It is the drug of choice. Penicillin G is the drug of choice for syphilis. Penicillin G is also the drug of choice for diphtheria. Okay, so these are the various organisms where the penicillin group of drug will work. So we are discussing the beta-lactam drug in ranging from the lowest spectrum of activity to the higher spectrum of activity. The lowest spectrum of activity of class of drug is penicillin group of drug. The next group of beta-lactam agent are penicillinase resistant penicillin. The basic drawback of penicillin group of antibiotic, what we have discussed in the previous slide, is they are destroyed by penicillinase enzyme. As a result, Staphylococcus aureus, which used to be sensitive to penicillin earlier, now 90% of Staphylococcus aureus are resistant to penicillin because of production of penicillinase enzyme. So that is why the next class of antimicrobial agent were discovered, which are called as penicillinase resistant penicillin. This class of antibiotic, the classical example is oxacillin, cloxacillin, dicloxacillin, methicillin. So this group of antibiotic, they have a property of resisting penicillinase enzyme. So these are called as penicillinase resistant or penicillinase stable penicillin. These are also popularly called as anti-staphylococcal penicillins. So their mechanism of, there is a spectrum of activity include they act on Staph aureus. Okay, they act on Staph aureus, but please remember they can also be resistant to Staph aureus by altering the penicillin binding protein. So when the penicillin binding protein gets altered to penicillin binding protein 2A, then the Staph aureus will become resistant to this group of anti-staphylococcal penicillin. Those phenotype of Staph aureus are called as MRSA, stands for methicillin resistant Staph aureus, though they are called as methicillin resistant Staph aureus because the target site has been altered, so they are virtually resistant to all antibiotic, all beta-lactam antibiotic. Okay, so kindly remember MRSA strain is the word MRSA is a misnomer. It is not alone methicillin resistant, it is resistant to all beta-lactam antibiotic. Okay, so the next class of antibiotic what we'll discuss is aminopenicillin or extended spectrum penicillin like ampicillin and amoxicillin. In addition to the spectrum of penicillin group of antibiotic, the ampicillin and amoxicillin, in addition, they also act on gram negatives. They also act on gram negatives. They act better on enterococcus. So these are their additional spectrum of activity. Okay. So the next class of antibiotic what we'll discuss is anti-pseudomonal penicillin. So their spectrum of activity is like same as the previous group, that is aminopenicillin spectrum, plus they also act on Pseudomonas aeruginosa. Okay, the previous group that is ampicillin, amoxicillin, they act on gram negative like E. coli. Okay, they act on gram negative like E. coli, however they do not act on Pseudomonas. Whereas the next group is anti-pseudomonal penicillin, which include carbonicillin, ticarcillin and penicillin. They act on Pseudomonas aeruginosa. Mechanism of resistance is same for all beta-lactam antibiotic what we have discussed earlier. So that's why we are not again and again. The next group is beta-lactam, beta-lactamase inhibitor. So there are few antimicrobial agents which are available. There are few agents which are available known as beta-lactamase inhibitor. Okay, so this agent they inhibit the beta-lactamase enzyme produced by the organism. So when you combine this agent along with the beta-lactam drugs, the combination drug will have a property of inhibiting the beta-lactam enzyme produced by the organism. The classical example include ampicillin sulbactam, okay, amoxiclav or amoxicillin clavulinic acid, okay, The previous class of enzyme, that is antibiotic, that is anti-pseudomonal antibiotic, the classical example is piperacillin, carbamazepine and ticarcillin. So in this you can take one antibiotic known as piperacillin. This combination is available along with tazobactam, piptaz. So this kind of antimicrobial agents are commonly used, and the advantage is they will overcome the resistance due to beta-lactamase enzyme. They will destroy the beta-lactamase ring. Okay, the next group of beta-lactam antibiotic include cephalosporins. The mechanism of action and the mechanism of resistance for all beta-lactam are same, so we are not discussing again and again. Under cephalosporin, there are five classes of cephalosporin. The first class include cefazolin and cephalexin. They are having mostly gram positive coverage. They have mostly gram positive coverage. The second class include cefoxitin, cefaclor and cefuroxime. They have same activity as first group, plus they have increased ZMB activity, gram negative activity. The third group include ceftriaxone, cefotaxime and ceftazidime. They are widely used in the hospital. They also have the same action as the second group, but the difference is they have more ZNB activity and they have reduced gram positive activity. Okay, in that some of the antibiotic like ceftazidime will have pseudomonas activity also, anti-pseudomonal activity also. Fourth class of cephalosporin include cefepime and cefpirone. They have increased gram negative activity, including pseudomonas. Okay. The fifth generation antibiotic is ceftobiprole and ceftaroline. So they are the fifth generation cephalosporin. They are active against MRSA. In fact, they are the only beta-lactam group of antibiotics which have anti-MRSA activity. Okay, the first, second and third class of generation of cephalosporins, they are usually inhibited by ESBL enzyme. They are the extended spectrum beta-lactam enzyme, mainly produced by gram negative organism, and these gram negative organism, because of this enzyme, they destroy the beta-lactam ring of the first, second, third generation cephalosporin. Okay, so now we will discuss about the next class. The next class of beta-lactam, they are the carbapenem. They have the highest spectrum of activity. These are the lowest spectrum of activity of beta-lactam are the penicillin. The next is anti-staphylococcal penicillin. The next is aminopenicillin, which have in addition gram negative coverage. The next group is anti-pseudomonal penicillin. Then you have beta-lactam, beta-lactamase inhibitor group of beta-lactam drugs, the combination drugs. Then you have cephalosporins. Then the next class is carbapenem. Carbapenem has the highest spectrum of activity. They are having increased activity to gram positives, excellent activity to gram negative. They have anaerobic good coverage also. The classical examples include meropenem, imipenem, doripenem and ertapenem. Okay, they also can be resistant because of the similar mechanisms. The most common is production of beta-lactamase enzyme. The beta-lactamase enzyme which are resistant to the carbapenem group of drugs, they are called as carbapenemase enzymes. Of course, efflux pump or alteration of penicillin binding protein, these are the other mechanisms how we have discussed earlier. Okay, next is aztreonam, another group of antibiotic. The compound is, the drug is again aztreonam. They have only one drug. The spectrum of activity include, it acts usually on gram negative organisms. Okay, the mechanism of resistance is same to any other beta-lactam antibiotic. So this is all about beta-lactam antibiotic. They are the most widely used antimicrobial agent in the hospital. Now we will discuss about other cell wall acting antibiotic. To start with, glycopeptides. Glycopeptide, the classical example is vancomycin and teicoplanin. Vancomycin and teicoplanin are the drug of choice for MRSA. I told you that for MRSA they are resistant to all beta-lactam antibiotic. The usual drug of choice for Staph aureus. For Staph aureus, the usual drug of choice is, anybody can, we have discussed earlier, anti-staphylococcal penicillin like oxacillin and cloxacillin. But if the Staph aureus will become resistant to oxacillin, those strains are called as MRSA. MRSA are resistant to all beta-lactam antibiotics. So for them, the drug of choice is vancomycin and teicoplanin. Vancomycin especially is the drug of choice for MRSA. They are also given for enterococcus. Vancomycin and teicoplanin are also recommended for enterococcus. They have good gram positive coverage. They do not have gram negative coverage. They do not act on gram negative organism. They act only on gram positive organism. The mechanism of action of glycopeptide like vancomycin and teicoplanin, they usually act on cell wall by inhibit the peptidoglycan side chain peptide D-alanine. D-alanine is the amino acids present in the side chain of the peptidoglycan. The vancomycin and teicoplanin, they usually act on this enzyme, act on this side chain, and they inhibit this. Thereby they inhibit the cell wall synthesis. That is how the vancomycin acts. And the mechanism of resistance to vancomycin and teicoplanin is just the opposite to that. They usually target, the organisms will change their target. The D-alanine, which is the target site of vancomycin present in the cell wall of the organism, that gets altered to any other molecule like D-alanine D-lactate or D-alanine D-serine. And these altered proteins will have less affinity for vancomycin. That is the mechanism of resistance shown by enterococcus against the vancomycin. Okay. The next class of cell wall acting antibiotic is fosfomycin. Fosfomycin usually act on the enzyme which is required. This enzyme is called as Murray enzyme, which is usually required for the synthesis of the precursors of cell wall. And when this enzyme get inhibited, as a result the cell wall synthesis get inhibited. Fosfomycin, the usual spectrum of activity, they usually act on enterococcus. They also act on E. coli and Klebsiella, but kindly remember they are recommended for the UTI isolates, the urinary tract infection isolates of enterococcus, E. coli, Klebsiella. They have access at the urinary tract. Okay. So this is about fosfomycin. The next cell wall acting drug is bacitracin. They are usually used as a topical antibiotic. A topical antibiotic for the ointment and antiseptic they are used. They are also of diagnostic use. Bacitracin is used for differentiating group A and group B streptococcus. The group A and group B streptococcus can be differentiated by using the antibiotics such as bacitracin. So these are the various cell wall acting antibiotic. The next class of antibiotic what we'll discuss is those which will inhibit the protein synthesis. The protein synthesis inhibitor antibiotic are broadly classified into The antibiotic which will inhibit R30S ribosome, and the antibiotic which will act on 50S ribosome. So the anti-30S ribosomal antibiotic include aminoglycosides, two important class, aminoglycosides and tetracycline. Aminoglycoside, there are various antibiotics. The classical example is gentamicin, amikacin and all that. They are bactericidal, okay. They usually act by irreversibly binding to the S ribosome. They have excellent activity for gram negatives. Also they can act on gram positive like enterococcus, but principally they have increased activity on gram negative. The mechanism of resistance shown by aminoglycoside include they act by producing various aminoglycoside modifying enzyme. They produce three important aminoglycoside modifying enzyme such as acetyltransferase, phosphotransferase and nucleotidyl transferase. So those kind of enzymes, they destroy the aminoglycoside molecules. So that is how the organisms so are resistant to aminoglycoside. They have another mechanism of resistance by decreasing the permeability due to the mutations in the outer membrane protein of the cell. Okay, so this is all about aminoglycoside. Tetracyclines are another class of antibiotic which also act on R30S ribosome. They block usually the tRNA attachment. Okay, the classical examples include tetracycline, doxycycline and minocycline. Okay, they have excellent action on various atypical organisms like spirochetes, rickettsia, okay, chlamydia, mycoplasma. They are also given for Bacillus anthracis, okay, and for other organisms like Brucella. So the mechanism of resistance to the tetracycline group of antimicrobial include either by expressing efflux pumps. Efflux pump will remove the antibiotic actively from the cell, or also by alteration of ribosomal targets. The 30S ribosomal target that gets altered. So these are about anti-30S antimicrobials. So now let us discuss the various anti-50S antimicrobial agents. These are the antimicrobial agents which act on 50S ribosomal unit. The classical example is chloramphenicol. Chloramphenicol was one of the most widely used antimicrobial in the olden days. The last few decades the use has been greatly reduced because of its widespread resistance, mainly because of the acetyltransferase enzyme production or efflux pump mechanisms, and also the chloramphenicol is highly toxic. So because of its resistance and toxicity, the use has been reduced, but it has a great activity on CNS. It penetrates excellent to the blood-brain barrier. So it has a good action on meningitis and brain abscess. So the clinical indication of chloramphenicol include brain abscess and meningitis. It has a good action on Haemophilus influenza, and also the agent of typhoid fever, that is Salmonella typhi. So these organisms are killed by chloramphenicol excellently. The next class of antimicrobials are the macrolide. The classical examples are erythromycin, azithromycin and clarithromycin. They have a good action on various atypical group of antibiotic like chlamydia, mycoplasma. Azithromycin is indicated for respiratory tract infection. Clarithromycin is given for peptic ulcer disease, for H. pylori. Peptic ulcer disease for H. pylori. Okay, so these are the various spectrum of activity of macrolide. The mechanism of resistance include efflux pump as well as alteration of the target site. Okay, the next class of antibiotic is lincosamide. The classical example is clindamycin. Clindamycin has a good anaerobic coverage. It also acts well on Staphylococcus aureus and also on Streptococcus, especially beta hemolytic Streptococcus. Clindamycin, the action is good in skin and soft tissue infection. Okay, so the various skin and soft tissue infection due to Staphylococcus aureus or due to anaerobic infection, clindamycin is one of the recommended antimicrobial. Next is streptogramin. Streptogramin, the classical example are quinpristin and dalfopristin. They act well on the organisms such as Staphylococcus aureus. They act well on MRSA phenotype of Staph aureus, and they also act well on Enterococcus. Okay, linezolid is the next group of antibiotic which act on 50S ribosome. It acts by inhibiting the initiation complex at 50S ribosome. Again, the action, the spectrum of activity include MRSA and Enterococcus. They usually act on gram-positive antibiotic. Mupirocin, again it acts on by inhibiting isoleucine tRNA synthase, and it is a topical antibiotic. Okay, and apart from its topical use, mupirocin is also used as an antiseptic as a nasal ointment for the carriers of MRSA. The nasal carriers of MRSA, mupirocin ointment is the recommended antimicrobial agent. So these are the antimicrobials which act on anti-50S ribosome. Now we will move on to the DNA synthesis inhibitor. So we have now completed the cell wall synthesis inhibitors, protein synthesis inhibitor. Now we will move on to the nucleic acid inhibitors. To start with DNA synthesis inhibitor, the classical two group of antimicrobial include fluoroquinolones and metronidazole. Fluoroquinolones, the classical examples are norfloxacin and ciprofloxacin. They have excellent activity on gram negatives. They are given for treatment of UTI, diarrhea. Okay, some of the antimicrobials like ciprofloxacin, they act on anti-pseudomonial also. Okay, the mechanism of action of fluoroquinolone include they are inhibitor of DNA gyrase. DNA gyrase and DNA topoisomerase, these are the enzymes which are required for DNA synthesis of the organisms. So the fluoroquinolones act by inhibiting these enzymes, and the mechanism of resistance involve alteration of the target, that is mutation in the DNA gyrase genes. This is the main mechanism. Other mechanisms include poor transport across the cell membrane. Okay, so the next class of antimicrobial is metronidazole. It has excellent activity for anaerobes. Metronidazoles, they act well on anaerobic infection. Apart from that, it has anti-protozoa action. It is given for Entamoeba histolytica, Giardia, Trichomonas. So for all this protozoan infection, okay, metronidazole is the drug of choice. Okay, next we will discuss about RNA synthesis inhibitor. Again, the classical example is rifampicin. It it inhibits the RNA polymerase. Okay, the spectrum of activity of rifampicin include it acts well on Mycobacterium tuberculosis and Mycobacterium lepra. It is one of the drug which is used in combination with other drugs for treatment of tuberculosis and leprosy. Okay, apart from that, its other use include it is also given for treatment of brucellosis. Also, it is given for as chemoprophylaxis for meningococcal infections. Meningococcal infection, rifampicin can be given as a chemoprophylaxis. Again, the mutation in the RPOB gene, the gene which the rifampicin usually inhibits, the mutation of the target gene is the principal mechanism of resistance. Next, we will discuss mycolic acid synthesis inhibitor. The classical example is isoniazid, which is again one of the most active drug for Mycobacterium tuberculosis. It is given along with rifampicin. So the action of isoniazid is by inhibiting the mycolic acid, which is present as a part of the cell wall of the Mycobacterium tuberculosis. Again, the mutation in the enzyme which is responsible for processing of isoniazid into its active compound, that is the CAT enzyme. Okay, the CAT-G enzyme, the mutation of this enzyme which is responsible for converting isoniazid into its active compound. This is the principal mechanism of resistance to isoniazid. The next class of antibiotic is folic acid synthesis inhibitor. The classical examples are sulfonamide and trimethoprim. How they work is they inhibit the various enzymes responsible for synthesis of folic acid. You know that folic acid is synthesized from a molecule called as PABA, that is para-amino benzoic acid, which is converted to dihydrofolate by an enzyme called as folate synthase. And the dihydrofolate can be further converted to tetrahydrofolate by an enzyme called as dihydrofolate reductase. Okay, so sulfonamide, they act by inhibiting the first enzyme, that is folate synthase. Similarly, trimethoprim, they act by inhibiting the second enzyme, that is dihydrofolate reductase. So the various examples under this antibiotic include sulfonamide. The commonly used antimicrobials are sulfadiazine and sulfacetamide. They are topical antibiotic. Sulfadiazine is used as an antiseptic for various burn wound infection. Trimethoprim is used in combination with sulfamethoxazole, and this combination drug is called as cotrimoxazole, and cotrimoxazole has various action. They are the drug of choice for various infection such as UTI and dysentery due to Shigella. They also act on various gram negative such as Burkholderia, Stenotrophomonas. For all these non-fermenters, cotrimoxazole act well. Okay, they also act on various parasites. They have anti-parasitic action like Toxoplasma. And cotrimoxazole also act on various fungi. They have antifungal action. The classical example is Pneumocystis jirovecii. Okay, so these are the various indications where cotrimoxazole is used. The most popular commercial name for cotrimoxazole is Septran. Okay. So the next class of antimicrobial is those agents which act on cell membrane. The classical example is polymyxins, which include polymyxin B and colistin. They have excellent gram negative activity They are one of the most highest spectrum gram negative antimicrobial available. Colistin and polymyxin, usually they are used in ICUs. They have excellent gram negative coverage, and also organism can show resistant to this antimicrobial either by efflux pump mediated action or alteration of the target. Okay, they usually act on the cell membrane. Daptomycin and gramicidin are the other antimicrobial which act on cell membrane. They act by forming pores on cell membrane. Daptomycin has excellent activity on gram positive organism like Staphylococcus as well as Enterococcus. They have good activity. The importance for daptomycin, what you need to know is, it is not active for respiratory infections. For the respiratory infections, it is not active because it is inactivated by pulmonary surfactants. It is inactivated by pulmonary surfactants, and therefore daptomycin should be avoided for various respiratory infections. Gramicidin, again it is of topical use, mainly it is active for some of the gram positive and gram negative antimicrobial. It is used mainly as antiseptic. Okay, antimicrobial resistance is defined as development of resistance to the various antimicrobial agents by the microorganisms. So the day of discovery of penicillin by Alexander Fleming, the next day itself the organism, the Staphylococcus aureus, started showing resistance to penicillin. So antimicrobial resistance is one of the reasons why the use of antimicrobial has been compromised. Okay, antimicrobial resistance broadly may be of two types: intrinsic resistant and acquired resistance. Intrinsic resistance means what? This kind of resistance the organism develop, organism show intrinsic resistance which is hereditary in nature. These resistance are inherently present in the organism, and they are, so such kind of organisms are always resistant to this kind of antibiotic. The various example include aminoglycoside, usually the various anaerobic organisms are resistant to aminoglycoside. The next class, like for example vancomycin. Vancomycin will be resistant by all gram negative organisms. Similarly, colistin, organisms such as Burkholderia, Proteus group of organism. Okay, so these kind of organisms are intrinsically resistant to colistin. It is very important for the clinician to know which antimicrobials the clinician must avoid in which infections, because intrinsic resistance means the organism will always be resistant to this class of antibiotic. But the thing is, intrinsic resistance is available only for few antibiotics. The various organisms, they are intrinsically resistant to only few class of antibiotic. So this is not a therapeutic challenge for the clinicians, because they know which antibiotic, which organism will be resistant intrinsically. The resistance which has a great therapeutic challenge is acquired resistance. The meaning of acquired resistance is the organism initially was susceptible to the antibiotic, later it will acquire the gene for developing resistant to the particular antibiotic. So this is called as acquired resistance. The development of resistance is acquired by the isolate. The mechanism of acquired resistance include, you just see that antibiotic pressure is one of the most important reason why acquired resistance occurs. So suppose before the antibiotic start, suppose the patient has been harboring a group of organisms in which the majority of organisms are susceptible to a particular antibiotic. Let us say the example is amikacin. So before you start up amikacin, suppose the majority of organisms are susceptible to amikacin. Maybe one or two resistant bacterium are present. What happens is when you start antibiotic, all the susceptible organisms will die because of amikacin treatment. What will remain is the one or two resistant strain. So that is called a selective pressure of antibiotic that leads to selection of the resistant isolates, which is followed by multiplication of those resistant strain because the nutrition what will be available is only for those resistant antibiotic. No resistant organisms, no susceptible organisms will be present at that moment. So the resistant organism will flourish nicely, and finally you will have a population of resistant strains. Those resistant strains then will spread in the environment. They will go from one patient to other patient. They will go from one environmental surface to other environmental surface due to poor infection control practices. So this is how the acquired resistance, and please remember, acquired resistance is a very important therapeutic challenge. The clinicians will be aware of the intrinsic resistance, as I told you earlier. However, the acquired resistance, the clinician will not be knowing. So, what are the various factors responsible for acquired resistance? As I told you, overuse and misuse of antibiotic. Overuse and misuse of antibiotic. You should not overload the antibiotic to the patient to treat various infections. You should give a targeted therapy, which is called as, first you should give an empirical therapy based upon what clinical syndrome you are suspecting, and for that clinical syndrome what are the common organisms which are responsible for that clinical syndrome. And the third factor which will decide is what is the common antibiotic resistant pattern for those organisms in your locality. Based upon these three factors, you start a particular empirical antibiotic. Then you send for cultures, and when the culture and the susceptibility report will be available, based upon that you have to change to targeted therapy or pathogen directed therapy. Based upon the culture report, whichever antibiotic is working, that particular antibiotic has to be given. So this is the correct method of antibiotic use. What happens is the clinicians often they will not know what organism is there in the patient, and they will just like that overuse or misuse antibiotic. Over the counter sell is one of the reason. Without prescription, the pharmacists they usually sell the antibiotic. That should not happen. If that happens, then the general public will start buying antibiotic. Already they are doing that. They start buying the antibiotic. So that leads to misuse and overuse of antibiotic. Next is poor infection control practices. So overuse and misuse of antibiotic will create antibiotic pressure, and when antibiotic pressure is there, one of the susceptible strain may undergo mutation and will become a resistant strain. But how that resistant strain will spread in the community or in the hospital, that happens because of the poor infection control practices, especially in the hospital environment, and poor disinfection practices. The resistant bacteria are easily transmitted to other patient or other environmental surface. So let us discuss the differences between mutational and transferable drug resistance. Mutational drug resistance, when the organism undergo mutation, it will maximum develop resistance to one drug at a time. Okay, and usually the resistance is of low degree. Therefore, because it is one drug at a time, the resistance can be overcome by combination of drugs. The classical example is the drugs used for tuberculosis. The anti-tubercular drug, tubercular drug, like how we have discussed isoniazid and rifampicin. The organism usually develop resistant by undergoing mutation. So the mutational drug resistance is usually of low degree. It will be one drug at a time. The organism will be resistant, and which can be overcome by using combination of drugs. This is the reason why the anti-tubercular drugs are given in combination. The virulence of the resistant mutants are usually not altered, or it may be even lowered also. And the mutational resistance is not transferable to other organism. It is only spread to the offspring by vertical transmission. In contrast, the transferable drug resistance is usually plasmid coded, and they are usually transferred from one organism to other organism by conjugation. Conjugation is the most common mechanism of transferable drug resistance. Rarely it can also be done by transduction. And here the drug resistance which happen is multiple drug at a time. The same resistant plasmid can code for the resistant genes to multiple antibiotic. Therefore, the degree of resistance is high, and because it is resistant to a multiple antibiotic at the same time, it cannot be overcome by use of a combination of drug, and the virulence here is usually not decreased, it remains intact, whereas the mutational drug resistance, the virulence may be lowered. And the transferable drug resistance, as I told you, it's spread by horizontal transfer, usually by conjugation, rarely by transduction also. Okay, so now we will discuss what are the various mechanisms by which the organisms develop a resistance. Broadly, there are 4 mechanisms. Decreased permeability across the cell wall. Okay, the organism, the antibiotic entry will be inhibited because of decrease in the permeability across the cell wall. This happens because of the mutation of outer membrane proteins. Outer membrane proteins are usually present as a part of cell wall, usually seen in gram negative organism. So that gets altered. As a result, the influx of the antibiotic into the cell will be prevented. Next is by efflux pump. Efflux pump means what? Organism, they undergo a mutation to carry various efflux pump. The role of the efflux pump is it actively remove the antibiotics outside. Okay, so antibiotics will enter into the cell, into the bacterial cell. Before the antibiotic will act, the efflux pumps are present in the cell wall of the organism. It will actively remove the antibiotic out of the cell. Efflux pump is another mechanism by which the organism may be resistant to several antibiotics at the same time. The most common method of antimicrobial resistance is by enzymatic inactivation. Various organisms, they produce several enzymes by which they become resistant to various antibiotics. The classical example is beta-lactamase enzyme. I will discuss about various classes of beta-lactamase enzyme in the subsequent slide. These enzymes, this group of enzymes are responsible for destruction of beta-lactam rings which are present in the various antibiotics of class beta-lactam. Okay, it is also, the organism can also be resistant to various aminoglycosides by producing various aminoglycoside modifying enzymes. The aminoglycoside modifying enzymes such as phosphotransferase, we have discussed about this earlier also. Phosphotransferase, then N-acetyltransferase, then nucleotidyltransferase. These are the 3 important aminoglycoside modifying enzymes which is responsible for developing a resistance to various classes of aminoglycoside. Okay, so this is all about enzymatic inactivation. This is one of the most common method of developing resistance. The last but the most important is modification of target site. Okay, MRSA. MRSA, I told you earlier that the target site of beta-lactam antibiotic, that is the penicillin binding protein, this gets altered to penicillin binding protein 2A, and the altered protein has less affinity for the beta-lactam antibiotic. Like that, the various target site of the bacteria in which the antibiotic will act, those target site get altered. Apart from MRSA, the other examples include the mechanism of action of vancomycin resistance in Enterococcus, VRE. Vancomycin resistant in Enterococcus. This also occurs because of the target site alteration. The target site is D-alanine sequence. This gets D-alanine is a side chain in the peptidoglycan. This gets altered to D-alanine, as I discussed earlier, D-lactate or D-alanine D-serine. This is responsible for resistance to vancomycin. Okay, so these are the various examples of modification of target site. Okay, we have discussed the various mechanism of resistance by the organism. The most important mechanism of resistance is by production of various enzymes that will inactivate the antibiotic. Okay, the classical group of enzyme is beta-lactamase enzyme. A beta-lactamase enzyme can be classified in various ways. Two important classifications are there: Ambler classification and Bush-Jacobi classification. Bush-Jacobi classification is a very complex classification. We will just try to discuss the Ambler classification, which is the structural classification. According to this, 4 classes of beta-lactamase enzymes are there. Class A is ESBL, stands for extended spectrum beta-lactamase. Okay. Class B is metallo-beta-lactamase, MBL. Metallo-beta-lactamase enzyme. Class C is AMP-C beta-lactamase, and class D is oxacelinase. So what happens is, the class A, that is ESBL, extended spectrum beta-lactamase, the organism producing ESBL enzyme are usually resistant to the penicillins, first, second and third generation cephalosporin, and also by aztreonam. Okay, and the resistance can be overcome by use of beta-lactamase inhibitor. For example, amoxicillin clavulanic acid combination. Okay, so ESBL enzyme produces into first, second, third line cephalosporin, and which is overcome by the addition of beta-lactamase inhibitor. Then comes to AMP-C beta-lactamase. In addition to the spectrum of class A, in addition to the spectrum of ESBL, the AMP-C producers are also resistant to the cefamycins such as cefoxitin and cefotetan. And this is the first difference, and the second difference is the resistance cannot be overcome by addition of beta-lactamase inhibitor. Okay, the resistance cannot be overcome by addition of a beta-lactamase inhibitor. So the only option available for AMP-C beta-lactamase producer is carbapenem. Carbapenem can act on AMP-C producers. MBL or metallo-beta-lactamase, in addition to AMP-C spectrum, AMP-C beta-lactamase spectrum, they are also resistant to carbapenems, and the resistance cannot be overcome by addition of beta-lactamase inhibitors. So the option available to treat metallo-beta-lactamase enzyme producer is you have to change the class, you have to give any other class of antibiotic, not beta-lactam antibiotic, because they will be resistant to all beta-lactam antibiotic including carbapenems. Okay, so the clinicians need to have an overall idea about the various classes of beta-lactamase enzyme. What are the therapeutic options available for them? I repeat once again, the therapeutic options available for ESBL enzyme producer include either you can give cefamyces or you can give carbapenems, okay, or you can give carbapenems, or you can give beta-lactamase inhibitor combination like amoxicillin. So these are the three options available for ESBL producer. Whereas for AMC producer, the resistance cannot be overcome by addition of beta-lactamase inhibitor. So that option is not there for you. So also the cefamycin you cannot give. So the only option available is you can give carbapenem. For metallo-beta-lactamase, carbapenem also you cannot give because it is resistant. Of course, it cannot be overcome by addition of beta-lactamase inhibitor. So the option left for the clinician is you should switch over to other class of antibiotic like aminoglycoside or any other class. So here are some questions for you. The first question for you is beta-lactams act by. Okay, the answer to this is beta-lactam act by inhibiting the cell wall synthesis. The next question for you is in MRSA, that is the methicillin resistant staph aureus, the mechanism is due to what? Answer to this is MRSA, the mechanism is alteration of the target site, that is the penicillin binding protein gets altered to a penicillin binding protein 2A. The next question for you is in ESBL mediated resistance, that is extended spectrum beta-lactamase mediated resistance, the mechanism is due to what? Here the answer for you is by enzymatic inactivation. ESBL is an example of beta-lactamase enzyme. ESBL stands for extended spectrum beta-lactamase enzyme. This enzyme will inactivate the beta-lactam ring. As a result, the beta-lactam drugs, the organism will become resistant. To summarize, in this session we have discussed about the various classes of antibiotic. We have also discussed the various mechanism of antimicrobial resistance. So I hope you have enjoyed the session. Thank you.